Good morning and welcome to Bonita's House Call here on SABC2. Bana bamangkhawulise ngumthwana, bantu abakaphala, abantu akamjokwana kandaba ngithi kunina nonke ebukhosini. I'm Dr. Victor Aramadiseli. Now, obesity has become such a common occurrence in our societies that no one of us is spared its devastating effects in one way or another on our health as well as well-being. But even more distressing are those people who exercise, eat well, and do everything according to the book. Kodwa amafutha amenqi okwenkani yeselesele. Manje kwenziwa njani makunje? Yiza nendlebe size nendaba. Let's watch.
The field of endocrinology and metabolic surgery has received much attention internationally in terms of research, since it is thus far proven to be the only successful treatment for sustained weight loss. There is a worldwide drive to regulate the field of metabolic surgery through accreditation and proctoring. In patients with a BMI of 35 to 40, evidence and treatment of comorbidities such as high blood pressure, high cholesterol, and diabetes need to be present to qualify for metabolic surgery. For patients with a BMI of 40 and above, it is understood that some or all of the following comorbidities will be present: coronary heart disease, type 2 diabetes mellitus, obstructive sleep apnea, obesity hyperventilation syndrome, hypertension, dyslipidemia, which is an abnormal amount of cholesterol and or fat in the blood, gastric esophageal reflux disease, and severe osteoarthritis. There are currently 10 accredited bariatric surgery centres in South Africa, and the centre at the Waterfall City Hospital is not only unique because it has an endocrinologist at the helm, but also because it is the only IFSO internationally accredited centre in South Africa. The centre has performed 1,078 bariatric surgery cases to date.
Whoa, and they talk about Professor Tessa van der Merwe, and we have her right here in the studio this morning. Professor, good morning.
Good morning, Victor.
Thank you very much. Tessa, is it Teresa in full, or what is Tessa? Is it something?
Say that again, Victor.
I say your name, Tessa. What is it in full?
What?
In full, is it Teresa or is it Tessa just as a name like that? I'm just asking.
You caught me on my backing. My Christian name is actually Maria Teresa. And Tess is actually just an abbreviation.
Oh, Maria Teresa.
Yes.
Oh, okay, beautiful. I just thought I must make it clear because we've been several times in the studio. I've been asking myself, what does it... Now, you talk about, you are the center that you are heading. The bariatric center that you're heading is the only one that's got an IFSO. What is this accreditation?
Yes, Victor, we are accredited by the International Federation for Surgical Obesity. So worldwide, there is a drive towards performing bariatric surgeries in accredited centers to make it more safe for the patients, to minimize the amount of complications. And in order to qualify for international accreditation, you've got to meet certain criteria. You've got to have at least 2 assistants, surgical assistants to your primary surgeon. You've got to perform more than 200 surgeries a year. You need to have an endocrinologist driving the team. And of course, then all the other things that we have as a standard requirement for accreditation.
So bariatric surgery is a multidisciplinary arrangement. It's not just one surgeon who's cutting and putting that piece and that piece together and interfering with the stomach. It is an endocrinologist at the helm and a whole host of other healthcare professionals who actually prepare that patient for surgery and actually for life after the surgery. Am I right?
I can't emphasize that enough, Victor. You can't leave any aspect of the treatment of the patient out of the equation, because you've got to take a person that has developed certain coping skills in the past and modify their lifestyle, their perceptions, their goals, their expectations to be able to cope with what they are going to do after the surgery. Without that particular part of the treatment, the patients will fall short of the goal. And I have a nice way of explaining to the patients that the surgery may be the most momentous part of their treatment. It's very exciting for them that day when it finally happens for them, but it's by no means the most important, because the preparatory phase, making you safe for the surgery, putting you through the process of education and understanding, and then finally dealing and coping with that kind of lifestyle afterwards is very important. It's a process of taking a patient from an abnormal lifestyle to a normal lifestyle, and old habits die hard. You can't wake up the day after the surgery and say, oh, Prof. Tess, what am I supposed to do now? That's way too late. You need to have had your education and your practice runs beforehand.
Now, bariatric surgery has had a bad name. I'm sure you'll be the first one to attest to this. And lots of people who have gone through the operation, some of them not particularly qualifying for it, and some of them, the people who are performing it, not doing it properly, and lots of complications have arisen out of some of those processes. Now, how has that happened, and how are people getting to know that now I'm doing it for the right reason, and it's actually now being done by people who are properly qualified to do it?
We've got a distressing situation in South Africa, in that once a surgeon has qualified for his specialist degree, there's no association that can dictate to them what surgeries they will or won't perform. So it's a process of peer review. The centre themselves have to adhere to the process of accreditation. And you will always have these fly-by-nights, people who take the shortcuts and doesn't want to go through the whole process of accreditation.
So in South Africa, will you say, therefore, it is only certain accredited centres that people should be going to, and should not be going to anybody else who purports to be an expert in this?
There's no question about it, Victor. I mean, if you want to go through a safe elective procedure, you've got to adhere to all the principles.
Okay. Now, Bonita Sounds Call will be bringing you a show every 3 months to follow the life of this beautiful lady as she embarks on a very tricky trip of undergoing bariatric surgery. But who is Lele Sithole? Let's find out.
She's always upbeat, she's always bubbly, she's fun, but she's still my elder sister. I know throughout our friendship, she's always been the strong one, you know, and she's somebody that you can actually talk to about anything.
I strive as much as possible to have some structure and control in my life. You know.
She's a very, very giving person.
I can be tough sometimes. My kids probably would tell you that. I'm not negotiable on a lot of things, particularly school things, their behaviors.
She's a very, very strong person.
That's me, very open, very flexible, very welcoming. That I would like to believe people who asked about me would tell you that.
So a very giving person, a very passionate person, a very loving person, and a very good mother.
But that's basically who I am. Just a simple person. Around 17, 18, I started picking up that I'm not comfortable with the weight that I have. And it's been a battle, you know. Since then, I've been on some weight, some watchers or some diet or the other for as long as I can remember.
I think we started some 2 years ago who gained this weight the first time I qala usebetsa, that was kabo 1998. She gained a little bit of weight, and then she took something I could say very quick slim slim. She took that thing and ababa slim. You know these things, once you also maintain, then you gain weight. After some time, I buy that thing, and then you weight. But it's in this one. This is now too much.
If I can tell you what I've been through, it's a long list. I can tell you what I have not done. I think that's the only one I haven't, and that's the one that says the blood type is this, and that's the only one I've never done. But everything else, believe me, I have done.
She tried various things. She tried gym. She was very religious about gym at one point, but what it did, it gave her muscle. It toned her instead of making her lose weight. There was a diet that she tried, I'm not sure what it was, but it made her lose weight. She went down to size 36, I remember, but that didn't last too long. Then she gains the weight all again. So yeah, she's been through various ideas and various things that she's tried. I know I've tried with her as well. Various things that we've done, going to different institutions, trying out different things. But sometimes she's very busy at work, very hectic. So sometimes she can't make appointments that are required for those things to happen. So yeah.
I went to work last week, and the first 2 days I didn't eat the whole day. You know, so that's the kind of thing I do. So the whole day will go by, I will not eat anything. And it doesn't bother me. I have no problem. As long as I have a cup of coffee in the morning. I eat because I am desperately hungry at that time, you know. Sometimes it's hard. You know, there was a time when it was just easier to eat out or to bring something in and have that at home, you know. So I would like to believe that that had some contribution. And obviously the fact that there's not enough physical exercise could have contributed a big deal to that as well. So it's a combination of a lot of things.
We always said it's probably in our genes that, you know, you had to gain weight, you know, even though you try very hard to you know, lose weight. Because we've been through the journey as well of going to gym. You end up giving up, you know. So when it comes to food, I know she's a very healthy eater.
I've encouraged her to exercise with me every day. We go running or we go walking, and she's put me and her on a particular diet because I'm there to encourage her to eat healthy and keep on exercising every day.
Ai siyabuya mana awusilele ngiyabona ukuthi uri mahinya mole ibili bawuqinto ezimnandi ngiyabona uyahlanganisa. But very interesting story. I mean, we're going to be following up Lele, I mean, throughout the process, almost for the whole year, walking the journey with her. But there are two things that I can pick up in that discussion. She says she has tried everything. Is this really a problem that you find?
Yeah, she has really tried everything. We turned her history upside down, Victor, and there's absolutely no doubt about it that Lele has tried her best. She's lost the weight, can't maintain it. She's the perfect candidate for the surgery in that she had the realization that her health was slipping. She's got a high-profile position. She realized that she was not performing to the level that she wanted to anymore. In fact, when she came to me, she didn't even understand what comorbidity she may have. And we actually found on her first visit for her blood pressure to be very high. So Lele's instinctive perception about her health status was very astute. And I think that, you know, she has got perhaps a genetic predisposition that has come through.
Let's hold it there. Let's hold it there. Don't forget to join our discussion by calling us on 083-913-4687 with your questions and comments on bariatric surgery. You can send your SMSs to Bonita 33723. We'll continue our journey with Lele's Tall. Hangang Rukhuta Papazo, Haramateula. You stay with us.
What can I do? I'm tired, I've been doing this, what else can I do? Then I come across this BMI again, and there's some tool that you use to calculate your BMI. So I go there, they want your weight, they want your height, and I put it there, and it popped back at me. I think it was sitting at 49, if not 50, and it said I'm sitting on the obese. I'm like, no, hell no. My knees were starting to feel my weight. You know, that's why I was getting concerned and doing a lot of research around what now. You know, where do I go from here? So I was on supplements for my knees because they were taking a bit of pressure for my weight.
Recently, we went to KZN on vacation. I could see that she was not enjoying the holiday because now unaseta affect everybody. As I feel like going out because na azale ke mo botse, but I could see gore ke taba air weight I mo tshware gantle.
My beloved GP, Dr. Tlede Krupp, she's been our family doctor for a long time now. And I think she's aware of my weight challenges because I talk openly with her. And ultimately I got to a point early last year where I said to her, no more. I don't want to talk about this thing anymore. I want to do something about it. And this time I want to do something lasting. And then she said to me, why, Lilia? Why all of a sudden? Why this passion about. I'm like, you know what, and I've got 2 kids now, and the other one's 10 years old, the other one's almost grown up, so not really a big deal. I could buy some time if I wanted to continue this way, but the other one's 10 years old, so I really want to be there for her when she matriculates. I want to be there for her when she graduates. Yeah, she told me about a center of excellence in Midrand at the Waterfall City Hospital in Midrand, to say there's a team of doctors there that assists people to manage and address issues on weight. And I said to her, I'm not looking for some quirky doctor. I'm tired. I've been prescribed, I've been analyzed, I've been measured, I've been weighted. I don't want anything fancy. She said, no, this is not quirky. This is really legit. And then she said it was Professor Tess. And she then wrote a referral letter for me to say, you can go consult with them. But she warned me to say, it's not an overnight thing. You're going to walk a journey with them. I'm like, so I didn't even hear her, because I was very excited that I had a referral letter. Now I'm going to find somebody who's going to help me long term now to sort my weight issues out. So that's how I got to know about her, through my GP.
It's been something that I know she wanted to do, but obviously everybody around her was worried about her going through the surgery.
When Lele told me about this bariatric surgery, well, in the beginning, I thought, it's one of these many slimming things selling in the market.
I was a little bit taken aback, because I knew my mom was a little bit reluctant and a little bit hesitant regarding the side effects.
But then she insisted, and then I became concerned. How sure are you this thing will produce results?
So I'd already done a bit of research by the time I had made this decision, because I knew there was something out there like that. But obviously, that's why I said I don't want a quickie doctor. I want somebody who knows what they're doing.
As my mom takes this weight loss journey, I'd like to tell her to not give up and keep on going, because she's a real inspiration for me day by day. To see her do that, it'll also push me to do better.
Lele's mom doesn't just she remind you of many other moms out there, Malokshin, who are very conservative but very supportive of their children. How did you explain bariatric surgery to Lele's mom to also feel comfortable for her daughter to undergo the process?
I think, in fact, Victor Lely explained it to her mom herself. And, you know, we spent a considerable amount of time and hours explaining to Lely the preparatory phase that she'll have to go through, and that she will have to adhere to certain lifestyle principles afterwards. I think what was primary in Lely's mind at that time is what would the complication rate be? And we went through a lot of facts explaining to her that the complication rate is in fact extremely low in experienced hands.
Hang on. Just lest we have somebody here who does not know what is bariatric surgery quickly, before we continue with the story. What is bariatric surgery?
I think that the best way to explain it to the public is that it's a hormonal operation.
Hormonal operation, meaning?
We modify the gut in such a manner that the satiety of the pituitary gland is enhanced. We bypass a certain part of the stomach and a certain part of the gut. It's not taken away and thrown out into a dustbin. It's bypassed because it secretes certain hormones that is making them more prone to having an abnormal metabolism and a higher sense of wanting of food. It's a complex process of stimulating appetite and inhibiting appetite. And this process of communication between the brain and the gut goes on all the time, Victor. It's a second-to-second, minute-to-minute thing that happens in the brain. And if you've got a genetic susceptibility to obesity, like Lely has got in her family, the functionality of those genes are not good. And we can, by changing the signaling process to the gene, actually change the whole process of perception in the brain as to what should I eat, how much should I eat, Do I want that? Should I not want that? And it's all a question of listening to those signals afterwards.
So in the end, it's not about how much you exercise. It's not about how much you're trying to diet and starve yourself. It is the relationship between your stomach and that part in the brain that says to you, you have eaten too much, stop now. So that communication between the stomach and the brain actually genetically gets dysregulated, disorganized. And through this process, through this operation, you try to realign what happens in the stomach and what happens in the brain, and so that you eat little and therefore you can maintain your weight. But anyway, let's hear more about how obesity occurs and affects one's health. Continue with Lela's story. And that's right.
In so many ways, obesity is such a tragic disease. It was given a disease status by the World Health Organization already in 1996. And I think since then, the scientific community has really worked tirelessly to identify the pathophysiology of why we have such a large epidemic worldwide and what are the consequences. And the principal consequence for us would be the tragic disease of diabetes. But we also see other associated comorbidities like a very high blood pressure, abnormalities of the coronary arteries of the heart, high cholesterol. We see fat infiltration in the liver, sleep apnea, arthritis of the joints, infertility, polycystic ovaries that makes a lot of our patients infertile at a very young age, and reflux that can affect the epithelial lining of the esophagus.
The psychological effects of obesity on someone are vast and varied. In principle, a person suffering obesity anywhere lives in a society that judges the obesity in a certain way. So, obesity is often loosely associated socially with all sorts of things, so slovenliness, disinformation, and so on. In principle, I think society sees, in terms of explaining obesity, it's almost as though your body is seen as a bag, and if it's big and rounded full, it means you filled it up last night and this morning, and society often deems the best solution is just eat less and move more. And it's a whole lot more complicated than that, because if that was how it worked, then the only people who would suffer obesity would be people of very low functioning maybe, and so on, and that's certainly not what we've found. So being obese in a society that's very judgmental often results in people being very judgmental of themselves, and that is a very significant thing to get a grip of early, especially for the long-term results of bariatric surgery.
But Prof, I saw Lele then, and I'm sure all the viewers will agree with me. She's not your huffing and puffing obese person. In fact, to the contrary, she can carry her weight quite well. Why are you subjecting her to this rather intricate, expensive, and elaborate process?
Victor, the bottom line is we underestimate what healthy weight is. Lely is at a BMI of 40.9, as she rightly stated.
Okay.
So,
which is weight divided by her height, and that gives you a body mass index.
Correct.
Normal is between?
For a person her age, we would say no more than 25 to 27
25
BMI.
to 27. And she is?
She's 40.9, and I think that we've become so used to seeing so many overweight and so many obese people around us in society. Two-thirds of our women are overweight, BMI 25 and above. One-third of our men. So we've become used to that as being the norm, until you one day say, I'm not feeling healthy. And then when you go to have your BMI calculated, you're faced with a harsh reality of actually being classified as obese. And I think that is where Lely's story is so beautiful. It's not just about that man that weighs 230 kilos or that person who weighs 190 kilos. It's also about the person at a BMI 35 and above.
And then you're operating on her purely based on her body mass index, which in this regard is very, very high and can begin to predispose her to a lot of medical conditions that might even shorten her life or even get the quality of her life to deteriorate so badly that she might not be able to function. Because I mean, she's quite a big executive. I mean, she's quite successful in what she does. But the advantage that she has is that she's quite enlightened, she understands. But she's also a human being. I mean, you could see even the manner in which she was preparing her food that, she still wants to enjoy life, but she realizes that she does have a major problem. And now we are going to take her through this process that is going to deal with the matter of the communication between the stomach and her brain so that she can maintain her weight. We'll continue our discussion on bariatric surgery here on Bonita's House Call. Stay with us.
The criteria that we use is a BMI above 35 plus 2 comorbidities. We do, however, also consider patients at a BMI 30 and above if they've got diabetes that cannot be controlled with medical forms of treatment. Although I have to be very clear that at a BMI between 30 and 35, the medical aids do not consider reimbursement. Medical aid reimbursement is considered at a BMI 35 and above. But once you have reached a BMI of 40 and above, you are considered to be morbidly obese, in which case, just by virtue of the weight, we expect you to have enough associated illnesses to qualify for the surgery. Good evening, Lely. We finally reached that stage where we are entering into the last phase of your preparation for the surgery, which of course is very exciting for both you and me. To recap on what we have found thus far in terms of your health, we know about the blood pressure problem. We know about the asthma. We've been treating both of those quite aggressively to get you into a better state of health. We found quite a bit of reflux on your history, and we'll see what your gastroscopy shows on Monday. And then, of course, the one worrying thing is that you've got this very strong family history of cancer. And we know that the relationship between cancer and obesity is quite significant. So you have multiple reasons why you have to address your weight.
My health,
And I think it's going to be a very successful journey for you. Obesity is probably one of the most difficult metabolic diseases to understand, and unless you have a sound understanding of the pathophysiology, you cannot advise the patient adequately as to why they ended up in the situation where they are and what the road forward would be. So they need a clear evaluation of their health status. They need a very stringent preparation period that involves the analysis of their comorbidities, their readiness for theatre, their dietary preparation, their psychological preparation. Somebody has to actually take all the different components of the team and pull them together into a workable format so that you can say to the patient, this is what we expect will happen before the surgery, this is what we expect will happen after the surgery, this is how we think you will improve, this is a risk for the surgery, this is a risk for the anesthetic. So it's practically impossible for a bariatric team to reach a true level of excellence without an endocrinologist being at the head of the team.
And we do have the endocrinologist in the studio. Now, this is quite clear. I mean, you have the endocrinologist who's yourself, who's sitting at the helm of the team, and you have a clinical psychologist, you have a dietitian, you have a psychiatrist, you have everybody. But why did she try many things, lost weight? In fact, she went down to size 36 at some point, only to regain weight.
It's the genetic set point. It's the most interesting phenomenon, Victor, that any person who's born with a certain genetic set point for their weight, the minute that they start losing weight, there are a whole lot of biological drivers, as we call them, that will get activated in the body that will actually say to the body and the pituitary gland, wait a little bit, you're actually threatening your own genetic set point, and therefore we are going to do everything in our power to drive you back
to your
now.
original weight,
Now,
yeah.
the interesting question here is very often that they will say, yes, but if I'm at that genetic set point, will I not go back to that weight? And the answer is no. That is exactly why we're doing a chemical operation. It's to actually change the dysfunctionality of what is happening between the brain and the stomach. And of course, the best way to do it is in the safest and most scientific way possible. So keyhole surgery with a short theatre time, a short anesthetic time, with a well-rehearsed team, on your feet 8 hours after the surgery. We want them out of bed. 2 days later, you've got to go home, and then your long journey starts to actually start adjusting your life from a previously abnormal lifestyle to normal.
So she's going to have keyhole surgery. You're not going to open up and stitch up again. It's going to be a very shortened keyhole surgery with no major component.
Correct.
But before we go to continue with the story, how much is it going to cost her?
She's going to get medical aid reimbursement, so medical aid is going to cover 80% of her cost. Her co-payment in total, that's including her hospital stay, for all the special investigations, the instrumentation, etc., will be in the order of about 15,000.
15, that's what she will pay, but the rest will be paid by the medical aid.
Correct.
Let us now hear Lele's case and what the clinical psychologist had to make of a state of readiness, and what the first time we see this tough SNA lady, for the first time you see her battling emotionally about the decision she has made. Let's watch.
My role is to help people prepare for surgery. Part of that preparation is really connected to where people are coming from before they even end up here. We live in a society that's quite judgmental about obesity and anything related to it. So very often people build up a whole list of expectations. There's more and more in the media now about bariatric surgery, some of it local, most of it, of course, international. So, a big part of it is helping them understand the context in which the surgery actually happens, and helping them not only with what to expect post-operatively and some of the changes they can expect and that they're going to go through, also preparing families for what happens, but also pre-operatively, people need to prepare for the lifestyle changes. The surgery is not a switch, it's a tool. So there's a lot that people have to adjust to make that tool work. And that in principle is my role. It encompasses quite a lot. This op is a beautiful tool, and your hand is ready for the tool when you're the person who's made those schedule changes, kept to them. Now, we don't know, we can't predict if you will, but that's a decision and we'll track it as we go. But to make those changes are massive. Obviously, we don't need you specifically to lose X amount of weight because you are a smaller patient for us. But we would like for you to maintain a healthy lifestyle and work with your dietitian.
I'm not actually worried about that. As I said, I think earlier on to you, like I've made a mind shift about it already. So my mind, it's sitting in the right place for it. And you're correct. I think you've put a thing on it. It's like it's what it is, and deal with it.
Yeah.
My biggest now that it's coming closer and closer. My biggest worry is my mind and my physique. I'm just worried about the balance. Like, you read on it. It says you lose 50%. You lose it sounds scary and overwhelming. So I'm worried that my mind might not move as quickly as my body is, and I might be caught up somewhere, and my thinking, I'm just worried about that post-op. I've become aware of my mortality, and it's unnerving. Thanks, David. It's quite unnerving. So yeah, that's why I'm doing this. I think when I did it previously, it was more for me. When I kept on doing all the other diets previously, it was more for me and how it made me feel, which is still important. I need to feel good about myself, because I think also that's something that I camouflage, and I do it intentionally. I do camouflage very well. I don't make it a big deal of my life, so I do what I do, and if you have issues with my weight, that's your problem, it's not my problem. So I just stay away from me. So I know how to, I don't let it sort of worry me. But yeah, when you get home and you're alone, that's when it starts hitting you, to say, I've got this issue now, I'm going up the stairs and I'm struggling.
and you're alone and it goes through your mind. So yeah, it's quite personal.
You go, girl. You have all our support. We'll continue our journey with bariatric surgery with Lela Sithole after the break. You stay with us.
At a clinic like ours is to get to know the patient, find out where they're coming from, their weight history, what previous diets they've tried, how much physical activity they do, how they generally eat, their general lifestyle. Then explain the dietary and nutritional implications of the surgery and what is required of them. And then together we try and plan an eating plan that is more appropriate to take them up to the surgery and also to give them an idea how they should be eating after the surgery. Then the last week, on the 16th of February, the last week is liquids only, a full liquid diet. What's a full liquid diet? Something that you can imagine sucking through a straw. Don't have to, but that's kind of like, even like a thick soup, but that you'll be able to suck through a straw. Okay. So now, what are the liquids that we'd like you to concentrate on or to have? Your skimmed or fat-free milk, fat-free yogurt, fat-free drinking yogurt like Jero, Woolies, any of those. Custard made with fat-free milk and sweetener, so buy the custard powder if you wish. Fruit puree like baby purities that you dilute with water.
We need to make sure that the patient is eating properly and is getting into good, healthy eating patterns and making lifestyle changes. We need to also make sure that when they go in for the surgery, that their body is in good condition so that they got all their nutrients and everything that they require. This is your throat or your esophagus and your stomach, and then your intestines. So what they do in the operation...
This is like a freeway.
Okay, well, I'm a dietitian, I'm not an artist, okay? So what they do in the operation, they'll make your stomach pouch smaller. So this is going to be about 30 mils. So it'll be about the size of an egg, so it'll be quite small. And then what they do is they join part of your intestine onto the stomach pouch like that. So basically, the food will go down here into the pouch, into this bit of the intestine, exactly, and down the other end.
So what happens to all this part now?
That's all going to stay exactly like that.
Isn't it going to rot or something?
Never, because over here you've got your liver, your gallbladder, things like that, and these enzymes and juices are still released, and they're just going to join a bit later.
Okay.
So the way you'll lose weight then is by restriction, meaning your portion sizes are going to be smaller, and then by malabsorption too, meaning that not everything is going to be absorbed. Because of this malabsorption, after the operation and for the rest of your life, you must take a multivitamin and mineral supplement every single day.
Because of this malabsorption?
Because of the malabsorption, yeah.
So Lela's going to be in theatre for an hour, you said. And she'll be back on her feet in 8 hours after surgery, and 2 days later she'll be home. Because you are causing a malabsorption. In other words, you are bypassing certain parts of the stomach and joining that part with the rest of the stomach, and like she said, is it not going to rot or something? So that is kept alive. So you're not taking anything out of her.
No, we're bypassing, and I must emphasize, Victor, the part of the gut that we're bypassing is actually very small. The calorie wasting is only about 200 calories a day. The reason why we're bypassing that particular part of the gut is because it contains those hormones and chemicals that we don't want to interact with the food.
I see, because it is those chemicals that make people to eat.
So we must not confuse this with the old banned malabsorptive procedures. I think that there's still a lot of misperception amongst the public from the JIB days when they used to rip out half of your gut, which was really just a tragic operation. And I find that even amongst the medical fraternity, a lot of people still don't understand that this is a very finely, scientifically tuned instrument. We bypass absolutely just that we have to.
Now, and you're saying Lele is going through the emotions that you normally see in these kind of patients, where they begin to think about the process and about the pros and cons. And I'm sure at some point she says, am I making the right decision? Or you think her mind is set?
this is exactly what we want. I normally say to the patients, if you're not contemplative, you're not ready for the surgery. So the whole concept of thinking about what I'm going to do, where I'm going to be afterwards, is a very important part. But Lely is very unique in that she feels a very strong moral obligation within her soul to educate the public about
Which
obesity.
is why she agreed to participate on this.
Exactly.
And a lot has been said about patients' mental state after bariatric surgery, but let's see exactly what impact that has.
Bariatric patients need psychiatric evaluation because it is important in terms of understanding their psychiatric status. It has been found that up to 2/3 of patients undergoing bariatric surgery have had a psychiatric disorder at some point in their lives, and about 40% of them have a psychiatric disorder at evaluation. This has been replicated in studies in the USA and Italy, where they found rates of about 50%.
Now you top it up with a psychiatrist now. Now I could see the role of the clinical psychologist, but why psychiatry? That sounds a little bit serious now.
We see a lot of reactive depression in patients who are overweight. We see a lot of anxiety. We see a lot of stress-induced coping mechanisms in the obese person. And
Before surgery, in other ways.
correct, correct. And I think that I always say to the patients, I can give you a fantastic tool, but whether you pass this exam with 70% or 90% is all going to depend on your preparation. And it's important for us to get the patient into a situation where they've got sufficient emotional reserves to be able to cope with a surgery. But in other words, we can't have them exhausted emotionally, depressed, anxious, not sleeping well at night. And this is all part of the preparation.
Are you saying to me, in summary, Professor Tess, the whole thing of saying to manage your weight, you need to eat well, you need to exercise, has got a big, big role to play in prevention of obesity and in managing obesity, but it has its limits. There are people in whom they can exercise the way they can exercise all day, they can eat almost nothing per day, and they will still be gaining weight. And these are the people that you would want to target for bariatric surgery.
That's why we've got an obesity epidemic. That is exactly the reason. We can't categorize everybody into the same category. Victor, there are some patients who will do well with lifestyle changes and not need the surgery. But we've got to open our minds to the fact that we have not won this epidemic. And one of the main reasons is because we keep on returning to the cliche of go and eat less, exercise more, and it'll be fine. And the answer to that is no, it will not necessarily be fine. And I think that the greatest gift that any generation can have is to know that we can change lives by understanding better and dealing with misperceptions.
Now, clearly this is something that Lele can afford because she's working, she's fully employed, she's educated, she can understand things. There are a whole lot more people sitting out there in the rural parts of South Africa, people who are not educated, who are deserving of this procedure and cannot avail themselves simply because of all those restrictions that we've spoken about. But this is a show for another day and a discussion that we can have in due course. We'll run up our discussion on the first leg of Lele's Toller's journey of bariatric surgery when you return. You stay with us. Watching Bonita's House Call here on SABC2 and welcome back. Now, Prof, what percentage of people whose obesity can be managed by lifestyle changes, diet, exercise, and whatever, and what percentage are these people who you could do anything you want, they will still be gaining weight?
We don't have an absolute value on that, Victor, but just generally speaking, about 10 to 15% of all obese people will qualify for bariatric surgery.
And what do you say about all those people who are sitting out there who are expecting services from the public sector? And I'm not sure if these procedures are available in the public sector, and those people who may not be educated enough to understand the intricacies and everything else and might just brush this thing away and say, look, I don't want to be open. How do you deal with that?
Victor, we've got to, this is a bridge that we've got to cross. I mean, this is a tool that should be available to all sectors of South African community. The problem point is the expertise that is required. And maybe I'm sticking my head out here now, but I think that the ideal route forward would be for government to contract to a center of excellence X amount of surgeries per year for those who are really needy and deserving, and we will take them on.
And Lele also has comorbidities. In other words, she has other medical conditions that are visiting her as a result of the obesity. And those are the conditions that, in fact, by her own admission, she had made her to arrive at this decision very quickly. And how important is that?
She's got quite severe asthma. It doesn't come across like that, but and hypertension and quite significant reflux. And
she's got a history of cancer in the family as well, which could
the
be
cancer history is absolutely overwhelming. And I think that what you want to look at is what is the health economic benefit 2 years down the line for a person like this, and it can only be positive.
So she will be going in there, and a lot of things are going to change, and you're preparing her for how life after the surgery, how she's going to deal with a new weight, a new wardrobe, a new way of life, and her way of eating is going to change significantly as well.
It is going to change significantly, but ultimately, for me as a physician, I want resolution of disease. I want a healthy Lele. She's not healthy anymore.
To you and your team, and to Lele as well, we want to wish you well in this procedure. We will be following it up with Bonita's house call, and we'll be bringing back to the viewers on the 24th of May, because we are going to theater with you. We are going to be talking to all the people around that, and we are going to bring to the viewer exactly what is going to be happening to Lele in that bariatric surgery. Bandala wethu sohlangana nodadewethu ke uLele ngomhla ka-24 kuMay, when we'll be taking you into theater and bring you a full report and a running commentary of the bariatric surgery she will be undergoing. We wish her and the medical team all of the very best, and we have no doubt that she is indeed in good hands. We'll be back next Saturday with eczema. Oh boy, so don't miss it here on SABC2 at 8:30 in the morning. Tato Haile Amrena. Thanks for joining us today. And for me, Dr. Victor Ramoresi Ramatesere. Ya khaula yaya. Ke namane tshehla modamo wa Mletsane. You take care.